To say the best doctors go there is ridiculous. In fact, I've often heard people say in the same evening that private healthcare takes all the best doctors, and in the same evening say there's evidence that private healthcare delivers worse outcomes. You help me figure that one out. And that profit is a bad thing. I actually, I'm a socialist, really. But my political beliefs are actually mostly socialist. I was a card-carrying communist at university, not ways to make more profits. We assume that the profit may come over time if we do our job right.
Now, there's some that argue that private options give us more choice. However, receiving health care is not like choosing a hamburger or buying a car. Patients often seek medical advice when they're feeling sick and vulnerable and are in no position to test drive or taste their options.
The bottom line is, I think that people should have the right in Canada to spend their after-tax dollars on better healthcare services or more healthcare services if that's how they choose to spend their money. A lot of people that come to our center are not wealthy people, but they've made choices. They made a choice, to buy a really good preventive health care package, for example, instead of the new giant screen TV or however else they're going to spend their money. It's just people have choice, and they decide how they're spending. We let people do all kinds of things. We let them buy alcohol, cigarettes, pornography, and everything else in this country. But if you have some after-tax dollars and you want more services from healthcare professionals, you can't. It's hard to get. I just don't think it's right.
If physicians also happen to have a strong vested material interest in the type of choices patients make, there is potential for abuse. So while the expansion of private delivery of services is not a direct challenge to the universality of our system, it still does not appear to be a good idea, given the evidence and ethical arguments against this. I would like to end by challenging all of us to encourage our leaders to carefully examine the evidence and to build sustainability in healthcare by expanding and improving the public system. Thank you.
We introduced the term zombies for ideas that are intellectually dead in defiance of all of the evidence, but you can't kill them. They won't stay buried. And a zombie has two features. One, it is that it's an idea that is superficially plausible. It just happens to be wrong. And the second is that it serves somebody's interests.
As a businessman, I can only tell you that if you provide bad outcomes and you're planning to be in private business making a profit, you won't be making profit very long if word gets out. So it's very, very oversimplified argument that in fact, I'll go back and say profit, the assumption is that if someone makes 15% profit in business, that somehow someone has been cut back, like someone has missed a service, or that we could have used the dollars better. But it's a really bad assumption, because the reality is, as long as we believe in a single-payer public system, if they make...
Yeah.
No, but it's an important point you make. You said...
Yeah, okay. Okay. A concluding sentence, Don?
I'm just saying, don't assume that when you contract with a private center, that you're not actually still saving net. And still that person the private company is making a profit, but it's still less expensive for the government. Don't assume that that's not the case.
All healthcare systems have within them three major axes of conflict. Doesn't matter whose system or, it's nothing peculiar to Canada. They seem to be particularly acute in Canada at the moment, partly for reasons that Dr. McGregor has mentioned, partly because we have the misfortune of living next to the world's most inefficient and inequitable healthcare system. But whatever the reasons, we seem to be engaged in these debates a bit more acutely, but they go on in all other countries as well. And those axes of conflict are, who, as it says on the slide, who pays, who gets, and who gets paid. Who pays? Answer is all of us. We don't get foreign aid for our healthcare system, unlike some smaller countries. But within that system, who is it that pays more and who pays less? How will the burden be distributed? Fertile ground for conflict. Second, who gets? What determines priority for access to healthcare? Again, separate from who pays, but lots of room for conflict. And third, who gets paid? Remember that every dollar of expenditure in a healthcare system is a dollar of somebody's income. So whenever you start talking about this program which I am going to introduce will save money somewhere else in the system, you should be asked, whose income do you plan to zap? Who's going to lose as a result of the cuts to costs that will emerge as a result of your favorite program? The private agenda, this comes in before the numbers, the privatization agenda is about transferring costs from the healthy and wealthy to the unhealthy and unwealthy. Anything you do that increases the proportion of private financing is going to have this effect. That's different from private delivery, which need not have that same effect. As Dr. McGregor pointed out, most physicians in Canada are private, but their bills are paid by the public. So shifting the funding mix is about transferring, and that's why the issue never goes away. These are fundamentally real conflicts of economic interest. And because they are fundamental and real, they can't be suppressed, they can't be solved, they can't be wished away. They're going to come back and back and back. And it really comes down to what kind of system do we really want? It comes down to the values, as the Romano and Kirby commissions emphasized. The improving the relative access for the wealthy. Again, most privatization proposals boil down to saying, do the wealthy and unhealthy get a better access than the unhealthy and unwealthy? And that, again, is part of what privatization is about. Increasing the incomes of providers. In mixed public-private systems, providers, UK is a good example, operate on both sides of the street, so they're able to do the wallet biopsy on their wealthier patients and say, well, you know, the National Health Service is underfunded and it'll be months before you can get your surgery, unless, of course, you're willing to see me privately, in which case we can do it tomorrow. Pull out your wallet and let's go. And that is, in fact, how it works. And that is how you would expect it to work. That's what economics is about. Do private providers lead to lower costs? Like hell they do. The costs of the system are their revenues. The drug industry is not interested in lowering the costs of the drugs. That's their sales. So it's just fuzzy accounting to imagine that privatizing delivery in and of itself will lead to lower costs. Now, if you had a way of inducing intense competition among private providers to force their prices down, which is what markets are supposed to do and don't do in healthcare, then indeed, perhaps private competitive delivery might lead to that. And in fact, the New Zealanders have been very successful in forcing competition among pharmaceutical companies and dramatically reducing the rate of growth of their pharmaceutical costs. But you have to structure the market. It doesn't happen automatically. Canada is actually, on this count, 13th in the world on private insurance. We don't think of ourselves that way, but when you actually add up the total numbers, we actually raise a relatively high proportion of our healthcare spending through private insurance. It's just that we don't do it for hospitals and medical care, which means we don't give privileged access to the wealthy among us, and that's a very severe fault in our system, which the privatizers look forward to correcting. Thank you.